And so while elite controllers in red here have lower immune activation levels, and this is just the measurement that we use, CD38 and HLA-DR expressing CD8 T cells, they have significantly lower levels of activation than people with high levels of viremia in yellow. They have significantly abnormal levels of immune activation compared to HIV uninfected individuals, and even significantly higher levels of immune activation than patients maintaining treatment-mediated viral suppression. So when the drugs are doing the work, you have less inflammation, less immune activation than when the immune system is doing the work of viral control. And so what's the consequence of that? Well, this is a cross-sectional study, so we can't prove anything here that immune activation is driving T-cell loss. But certainly there's a very strong correlation here that people with the highest levels, these are all the elite controllers here, people with the highest levels of immune activation on the x-axis here, have the lowest CD4 counts. And this was true for the frequency of activated CD8 cells and the frequency of activated CD4 cells as well. And again, to make this point that, not all these are necessarily HIV specific. This particular patient out here, over 60% of their CD8 T cells are activated. This is profoundly unusual. Usually we see around 10% in an HIV uninfected individual. So might there be other consequences of HIV-associated inflammation besides just loss of T cells? And we wondered about cardiovascular disease, and we wondered about this for several reasons. People in the HIV world had been really focused on whether protease inhibitors and the drugs that we use to treat HIV might be increasing the risk of cardiovascular disease, and that appears to be the case with protease inhibitors. There's very clear evidence it increases cholesterol levels, and it does appear to increase the risk of cardiovascular disease. There's now a debate about abacavir in the treatment world, but this is a very compelling study, the SMART study, published a few years ago now, and they randomized people to two different treatment strategies, continuous antiretroviral therapy, the standard of care now, versus interrupted therapy, where if your T cells went up above 350, you came off of therapy. As your T cells declined below 250, you went back on. Just an ARV sparing strategy to limit all these toxicities. And they thought, going into this, that people off of being spared the therapy would have fewer toxicities like cardiovascular disease, but they ended up seeing the exact opposite. So it was the people who were in the intermittent therapy arm who actually had higher levels of cardiovascular disease than people who remained on antiretroviral therapy. So take-home message, the virus was worse for you than the drugs. And so we wondered whether HIV-associated inflammation would be driving this cardiovascular disease. They have some follow-up data suggesting this was the case, with elevated inflammatory biomarkers predicting cardiovascular disease. So we wondered whether the elite controllers in our sample also had some marker of increased risk of cardiovascular disease. And we worked with Priscilla Hsu, a cardiologist just down the street at San Francisco General. She's been interested in these issues. And one of the studies she performs is measuring the amount of cholesterol plaque you have in the carotid artery. That's a very good predictor of cardiovascular risk. And when she compares the amount of cholesterol plaque in the carotid artery across various groups, she sees that HIV-infected elite controllers here in red actually have higher levels of atherosclerosis than HIV-uninfected individuals, and interestingly, comparable levels to people with much higher levels of viremia. On average, this is over 10,000 copies. And this difference remains significant after adjustment for typical cardiac risk factors: age, sex, cholesterol, smoking status, diabetes, hypertension, etc. So we think that HIV-associated inflammation may have negative inflammatory consequences, and we've wondered about what may be driving this inflammation in elite controllers. We think that the extent of low-level virus replication may be an important factor. Now, all these folks are defined by having a clinically undetectable viral load in the blood, so typically less than 75 or less than 40 copies per mil. But that doesn't mean there's no virus. In fact, we think that just about everybody has virus replicating if you look hard enough. And so we did that. We looked at, we used a very sensitive assay called the TMA assay to look for very, very low amounts of virus in the peripheral blood, and we see that a very weak correlation between the extent of low level of viral replication on the x-axis and the amount of inflammation experienced by CD8 T cell activation. But we wondered about other factors. Maybe it's not just simply the extent of virus replication. Might there be, Danny Dewick and Jason Brenchley at the NIH have explored this concept of microbial translocation, where you have a leaky gut syndrome in HIV. You lose tons of T cells in the gut, and you also get breakdown of that mucosal barrier. And so little bits and pieces of bacteria that are supposed to stay inside your gut and in your stool start leaking into your bloodstream, and that activates T cells. It activates the immune system. And they showed earlier that people with HIV have high levels of this compared to uninfected people. So we wondered about our elite controllers. They also had elevated levels of microbial translocation, we call this. High levels of lipopolysaccharides, these bacterial products, compared to HIV uninfected individuals in blue. And also, just paralleling the immune activation data that we have, they also have higher levels of microbial translocation than people who are on treatment and maintaining an undetectable viral load. So again, when the drugs are doing the work, you have both less inflammation and immune activation and lower levels of microbial translocation. And interestingly, similar levels of microbial translocation to people who had high levels of viremia. And the more that you had, the more microbial translocation you had, the more immune activation. And then lastly, we wondered whether the robust HIV-specific CD4 T cell response against HIV that we see in most of these folks might be contributing. We also see a very strong relationship between the frequency of HIV-specific CD4 cells on the x-axis and the frequency of activated T cells on the y-axis. This is a strongly significant association. We think of those CD4 cells that respond to HIV as being important players in maintaining an effective immune response against HIV, but it may be that they're also contributing to this persistent inflammation, which may have negative consequences. So our model is that HIV, through direct or indirect mechanisms, may be stimulating innate immune responses, which has both favorable effects by decreasing virus replication, but it may also have negative inflammatory consequences, generalized immune activation, which may lead to CD4 depletion. And so while we're focused now on the mediators of viral control to establish effective vaccines, I think the next generation question is really what are those mediators of control that also minimize these negative inflammatory consequences? Not all elite controllers are the same. Some control without a lot of inflammation, some control with quite a bit of inflammation. And understanding that riddle, I think, will help in designing a protective vaccine. And then lastly, I can close here. I think there were comments, there were questions submitted in advance about patients who are viremic non-progressors. The elite controllers who progress are in many ways the exact opposite of these pseudomangabe monkeys I told you about, who have high levels of viremia but don't progress. And so are there any people like pseudomangabes out there who have high levels of viremia and don't progress? And here's one from the SCOPE study, this is 15 years of observation, viral loads above 5 logs here, over 100,000 copies for many years, and T cell counts well above 500 for, again, over 15 years. And understanding how these folks fail to progress despite very high levels of viremia over long periods, I think will add important insights as well. So just close by acknowledging all of our collaborators, including some in the room.